Welcome back, everyone, to Decode Healthcare with Harshal. After last week's deep dive in Part 114, where we unpacked MDC-20 and alcohol-induced disorders, I am absolutely thrilled to have you back for Part 115 of our IPDRG Masterclass. Today, we're exploring the complex, high-stakes world of Major Diagnostic Category 21. We're specifically focusing on injuries, poisonings, and the toxic effects of drugs. This is literally where emergency clinical documentation crashes into incredibly rigid sequencing rules, and honestly, mastering it is the absolute foundation of revenue integrity. So, grab your notes and let's decode these systems together.
But before we get into the heavy lifting of today's material, I just need to quickly remind you, if you're enjoying this lesson, please like, share, and subscribe to this channel, and share it with friends for this free course on Decode Healthcare with Harshal. Your support is exactly what allows us to keep breaking down these complex healthcare concepts week after week.
Okay, let's dive into this. Today, we're covering an overview of MDC-21, the high-volume medical DRG families, T-code sequencing rules, clinical validation criteria, and finally, payer audit defense strategies.
Right, let's start with Section 1, an overview of MDC-21, which covers injuries, poisonings, and toxic effects of drugs.
The clinical scope of MDC-21 is incredibly broad. We're talking about the non-surgical management of acute traumatic injuries, pharmaceutical overdoses, accidental poisonings, toxic exposures, and adverse drug reactions. From a patient arriving after a massive motor vehicle accident to an admission for severe lithium toxicity, this category handles the critical, acute phases of emergency and toxicology medicine. The documentation here? It has to instantly capture intent, causality, and precise chemical agents. There is no room for ambiguity.
To properly navigate this, you have to understand its structural partitioning. The grouper logic splits cases down two very distinct pathways. The medical DRG logic handles poisonings, toxic effects of drugs, non-medicinal substance toxicity, and traumatic injuries managed without an operating room procedure. On the flip side, the surgical DRG logic captures major trauma, wound interventions, and specific device procedures. For today's explainer, we're remaining strictly focused on mastering that complex medical side of the logic tree. Moving right along to Section 2, the high-volume medical MDC-21 DRG families.
So the crucial point here is understanding exactly how different agents group financially. MSDRGs 917 and 918 are dedicated entirely to medicinal poisonings and toxic effects. This captures accidental poisonings, intentional self-harm overdoses, and therapeutic toxicities from prescribed medications. Think acetaminophen, opioids, or digoxin. Contrast that with MSDRGs 915 and 916, which are reserved for non-medicinal substances. This is where you map severe environmental and occupational hazards, including carbon monoxide poisoning, pesticide exposure, heavy metal toxicity, and even snake or scorpion invenation.
Rounding out the medical families, we have specific DRGs for traumatic injuries and treatment complications. MSDRGs 913 through 914 and 947 through 948 catch multiple trauma management, mild traumatic brain injury observation, and blunt trauma that simply doesn't require surgical intervention. Meanwhile, MSDRGs 919 through 921 are utilized for complications of treatment without an OR procedure. This includes things like non-surgical mechanical complications of catheters or severe adverse drug events that were actually administered correctly at therapeutic doses.
Now for Section 3, high-yield CDI and the absolute mandatory ICD-10-CM T-code sequencing rules.
Now, I might be wondering, what's really interesting about this? It's the rigid logic of the ICD-10-CM poisoning and adverse effect table, specifically regarding T-codes from T36 to T50. When a provider documents a poisoning, and it doesn't matter if it's accidental, intentional self-harm, an assault, or undetermined, the sequencing rule is absolute. The specific T-code for the poisoning must be sequenced as the principal diagnosis. Any resulting clinical manifestations, like anoxic brain damage, acute respiratory failure, or a cardiac arrhythmia, are sequenced secondarily. Remember, the drug toxicity drives the DRG assignment here.
And this brilliantly illustrates the contrast when we look at adverse effects. An adverse effect happens when a medication is correctly prescribed and administered at the exact proper therapeutic dose, but it still causes a severe reaction. In this scenario, the sequencing totally flips. The manifestation, the actual acute condition that brought the patient to the hospital, is sequenced as the principal diagnosis. The specific T-code identifying the drug causing the adverse effect is then sequenced secondarily just to provide context.
Let's move to underdosing, because this is a frequently audited area.
Underdosing happens when a patient takes less of a medication than prescribed, whether intentionally or accidentally, which leads to a worsening of their condition. The absolute golden rule here: an underdosing T-code can never be assigned as the principal diagnosis. You must sequence the clinical manifestation or the underlying condition that flared up as primary. Follow that with the underdosing T-code, and then, if you know it, the code explaining why the patient underdosed, like financial hardship, for instance.
All right, Section 4, Clinical Validation Criteria for Drug Toxicities and Chemical Exposures. Clinical validation is absolutely critical to surviving an audit. Take acetaminophen toxicity, for instance. A coder cannot simply take the word toxicity at face value without clinical backing. The auditors? They will immediately look for validation through the Rummick-Matthew nomogram, which plots serum acetaminophen levels against the time since ingestion to figure out hepatotoxicity risk. They're also going to look for the administration of the N-acetylcysteine, or NAC protocol, and significant elevations in hepatic enzymes. If those clinical indicators aren't documented, that toxicity diagnosis will absolutely be downgraded.
A very similar validation standard applies to non-medicinal toxicities, like carbon monoxide poisoning. Defending a severe CO poisoning diagnosis requires specific, rock-solid documentation of carboxyhemoglobin, or COHG, levels right upon arrival. Furthermore, auditors want to see aggressive interventions matching the severity of that diagnosis. They're looking for hyperbaric oxygen therapy criteria being met or continuous myocardial injury monitoring, because CO poisoning heavily impacts cardiac muscle. Which brings us to Section 5, Payer Audit Denial Defense Strategies and Compliant Queries.
Let's be real, MDC-21 is a massive target for payer audits, specifically regarding the inpatient level of care. Payers frequently try to argue that drug overdose observation stays should just be classified as outpatient. Your documentation has to paint a clear, undeniable picture of high clinical risk, unpredictable metabolic pathways, and the need for continuous acute monitoring to defend that inpatient admission. Plus, you have to proactively query providers to clarify intent. Was an overdose accidental or a self-harm gesture? And most importantly, you have to resolve any documentation ambiguity between an adverse drug reaction and an acute poisoning. Because as we just saw with T-codes, that distinction completely alters the sequencing and your final DRG.
Finally, Section 6, Masterclass Summary and Next Steps.
We've decoded a tremendous amount of logic today. Your golden rules for MDC-21 revenue integrity are crystal clear. First, you absolutely must master the strict T-code sequencing logic that differentiates poisonings, adverse effects, and underdosing. Second, ensure rigorous clinical validation is present in the chart for all toxicities, utilizing tools like the Rummick-Matthew nomogram. And finally, always clarify patient intent concurrently. I want to leave you with a provocative thought to carry into your daily work. Are your retrospective queries actually capturing true clinical severity and intent, or are you just perpetually fixing avoidable documentation gaps that leave your facility completely vulnerable to audits?
Thank you so much for your intense focus today. Next time, we're progressing into Part 116, where we'll shift our focus to the surgical side of MDC-21. We'll be diving into complex surgical procedures for trauma, injuries, and poisonings. Before you go, if you are enjoying this lesson, please like, share, and subscribe to this channel and share it with friends for this free course on Decode Healthcare with Harshal. Keep decoding, and I will see you in the next explainer.